Good afternoon, everyone. So it was early in 1998, and I was an assistant professor at the University of Kentucky. I'd been there just a couple of months. And I was in my lab one day, and there's a knock at the door. There's a young woman there that says she wants to talk to me about doing a rotation. And what's weird about that is I wasn't listed in any of the departmental materials yet. I was off in like a different building, so there was literally no way anybody should have been able to find me. But somehow this enterprising young woman had found me and ended up doing a rotation in my laboratory and liked it. And everybody in her department said, you know, don't go there. It's a new guy, he's doing this kind of weird leukemia stuff. You know, you should come back to the home department where we're doing immunology and it's some really interesting things there. And she said, no, I'm going to stick with this. So that turned out to be an incredibly fortunate thing for me, and I think a pretty good thing for her too, because Monica went on to pioneer some of the really important findings early in the leukemia stem cell field. So you have to realize 20 years ago that when people looked at normal stem cells and leukemia stem cells, there was really worry that they were going to be so similar, it's going to be very difficult to find ways to develop a therapeutic index and find differences that we could target. We now know, of course, that that's not the case, but at that time it wasn't so clear. And so the really seminal contribution that Monica made, actually as a graduate student, was to define the first molecular differences that separated a leukemia stem cell from a normal stem cell. And that was actually constitutive activation of NF-kappa B, which she then went on to show was actually a therapeutic target that could be approach with a viable clinical strategy, and was the first to publish on that. She subsequently went on to discover multiple novel small molecules that also were able to selectively target leukemia stem cells, and many of those have been pursued for therapeutic advantage as well. She had a really very important contribution early in her career, and her subsequent career as an independent investigator has continued to pursue those types of studies. As an assistant and now an associate professor at Cornell for about 10 years now, Monica has led their efforts working closely with their clinical program to develop new translational strategies. Of particular interest are the studies of the tumor-specific form of chaperonins that exist in many forms of cancer. She's been a real leader in pioneering that type of work in AML. She's also been involved with multiple NIH grants, Leukemia Society grants, was the recipient of the very prestigious DP2 award when she first started out as an investigator at Cornell, and has subsequently done a lot of really beautiful work around that. So Monica, thank you so much for being here today.
Well, thank you for the very nice introduction and for dating me how old I am. Now, as you can see, the title of my talk is Leukemia Stem Cells to Seek and Destroy. And pretty much I'm going to follow up on what Greg said. You might imagine, what is this? This is some sort of enterprise, some sort of role that we have to look, like a Star Trek. Oh, thank you. In case of, for the younger ones that don't know who these guys are, when I'm talking about enterprise and all of these are the younger version. But since all of this is dated, I think nowadays will be more appropriate to show the Avengers guy. What do we mean with to seek and destroy? To explain this, I have to go back 20 years ago, as Greg mentioned, just kind of to tell you on my side. When I started looking at these, leukemia stem cells were just identified. As Greg mentioned, 1997, 1998. I stopped by Greg's office, and he said, I have a project for you. And the project is, we have these two cells. One is a leukemia stem cell, and the other one is a hematopoietic stem cell. Phenotypically, they are identical, CD34 positive, CD38 negative, HLA-DR negative. One of them gives rise to leukemia, and the other one gives rise to normal hematopoiesis. And the project will be to identify differences so we can kill one but not the other. It's like wonderful, sounds like a great challenge, we'll do it. And that's why people used to think that we were pretty much crazy, because what we were trying to attempt was to fight the black Spider-Man pretty much, and leave the red one alone and trying to find differences. Now, many years later, we have been showing that this is feasible, to distinguish a leukemia stem cell from a normal hematopoietic stem cell, and that there is many different strategies to kill one without harming the other. So a general overview for today, what I'm going to discuss is going to tell you a little bit about leukemogenesis, leukemia stem cells, which you probably are very familiar with. the feasibility about targeting leukemia stem cells, and in particular, I'm going to discuss two projects that we've been working on. One of them is targeting the immunophenotype with CAR T cells, and the second one is targeting dependencies using epichaperone inhibitors. So to start, you probably know that the hypothesis of where leukemia starts or leukemia stem cells start postulates that from a normal hematopoietic stem cell or a hematopoietic progenitor that undergoes one or several oncogenic events will give rise to a leukemia stem cell. A leukemia stem cell is a cell that has the capacity to self-renew, just like a normal hematopoietic stem cell, except that the progeny will be a leukemic progenitor, which in turn will give rise to the leukemic blast. Now there is evidence that this happens in humans, and we've recently shown that pre-leukemic state or pre-leukemic mutations can be identified in individuals even 10 years before the disease is diagnosed. This was shown using a cohort of the WHI cohorts, where we were able to identify several cases, close to 200 cases of women that we knew developed AML, and we compared it to their control cases, which have exactly the same morbidities, except did not develop AML. These blood samples were taken when the women were enrolled into this study, and the women were followed for many, many years. So this blood was obtained before there were any symptoms or any signs of any hematologic malignancy or any hematologic abnormal parameters. And as you can see here, in the blood of these women, several mutations were identified compared with the controls, and all of these women developed AML between 5 to 10 years later. So this suggests that yes, leukemic mutations exist and precede the development of disease, supporting the hypothesis that early events happen in humans as well. However, for today's talk, I don't want you to focus on where leukemia starts or how it initiates. I rather want you to focus on what leukemia is. And leukemia is a heterogeneous disease that is composed by leukemic blasts, the leukemic progenitors, and the leukemia stem cells. And this has several therapeutic implications. The therapeutic implications is that when a patient comes to the clinic with AML and undergoes standard of care, this patient will go into complete remission. In this window of complete remission, some cells are left behind. And then among these cells are going to be the leukemia stem cells that have the capacity to give rise to progeny. And later on, this will give rise to disease relapse. This window of remission is highly important because there is a window where there is disease left over. And the challenge nowadays is to identify the residual disease. And that's why in this stage, we always measure what used to be known as minimal residual disease. And now it's called measurable residual disease because pretty much the limitation is the technology we have nowadays to measure and evaluate the disease that is left behind in order to be able to predict potentially when the disease, if the patient is going to relapse and when the patient will relapse in order to have better interventions. So there is now many papers that show clinical evidence of the relevance of leukemia stem cells. This is just two examples that have shown that patients that present higher proportions of CD34 positive, CD38 negative cells are going to have worse outcomes and are going to have higher levels of minimal residual disease, supporting the idea that it's important to evaluate and eliminate leukemia stem cell populations. So going back to how leukemia stem cells can be identified. So this was 20 years ago. Now we know that there's many different ways to distinguish the leukemia stem cell from the normal hematopoietic stem cell. And this slide is not up to date, but it's just to represent that there is some phenotypic difference between these two populations. It is important to point out that this phenotype of the leukemia stem cell is not going to be universal, so not all leukemia stem cells will present this phenotype in all leukemic patients, but provide a platform to start looking at differences on these two populations as we start studying AML patients and comparing it to normal healthy bone marrows. One of these important examples is CD123, which was the very first phenotypic marker identified by Craig Jordan. And when I was still in his lab, I was lucky to witness that. So then what is the clinical relevance that supports the role of leukemia stem cells? These are survival curves that show that patients that have putative, in this case they call them putative leukemia stem cell. As I mentioned before, this phenotype can vary from patient to patient. So patients that present higher proportions of putative leukemia stem cells are going to have worse outcomes compared with the patients that do not have these putative leukemia stem cells. And we're talking about proportions of higher than 0.1% leukemia stem cells. That would be considered positive. If you combine this definition of putative leukemia stem cells with the classic definition of MRD, you can see that you can further separate these survival curves, being the patients that have positivity for putative leukemia stem cells and positivity for MRD, the ones that are going to do the worst. So there is clear evidence that leukemia stem cells contribute to poor outcomes and that we need to study them better in order to hopefully have better prognostics and better outcomes for patients. But the phenotype is not sufficient to define and characterize leukemia stem cells. It's just a way to begin researching. The best way to define and identify a leukemia stem cells is using what we know as functional assays. What these assays measure, they measure the activity of stem and progenitor cells in many different ways. So, for example, if you take the bone marrow from a healthy individual and plate it in methyl-CoLT or methyl cellulose, you can evaluate colonies forming in this plate, and these colonies would be from normal hematopoietic cells. They will encompass erythroid, macrophage, granulocyte, macrophage colonies. If you transplant these cells into an immunodeficient mice, these mice will have normal human hematopoiesis in their system. In contrast, if you take a bone marrow from an individual with leukemia and use the same assays, what you're going to identify is that in the methyl-CoLT assays, you're going to find leukemic colonies. And in the immunodeficient mice, the animals will develop AML. And the gold standard for leukemia stem cell function will be the capacity to take the cells from mouse 1 and retransplant it to another secondary animal, showing that this disease can be maintained from generations to generations. So one of the very early assays we did 20 years ago to determine this importance or the ability of drugs to kill leukemia stem cells was taking total AML cells from patients and treating them with cytarabine, which at the time was the standard of care. And then we evaluated the cell survival of these cells. As you can see in here, in this corner, is showing you the live cells after treatment with RSE for 36 hours. And from this plot, you could conclude that this therapy works because the majority of the cells are dying. And it's exactly what happens in the clinic. Patients that undergo treatment with cytarabine and idarubicin, they will go into complete remission, the majority of them. However, they will eventually relapse and die of their disease. In contrast, when we look at the leukemia stem cell population from these same AML samples, you can see that most of these cells, the C34 positive, C38 negative cells, remain intact, demonstrating that these cells are actually chemoresistant. So based on that, many different groups, including ours and Craig's, have shown many different ways to eliminate or target leukemia stem cells. And this is just an example. We can target the immunophenotype. You can target signaling cascades, iron metabolism, mitochondrial function, leukemia niche, stem cell niche interactions, survival, epigenetic machinery, so forth and so on. There is so many ways to target these cells. Specifically today, I'm going to talk about how we can target the immunophenotype to eliminate leukemia stem cells without harming normal hematopoietic stem cells. We're specifically focusing on CD123. So CD123 is the transmembrane receptor of the IL-3 receptor alpha chain, and is expressed in normal cells, specifically in plasmacytoid dendritic cells, basophils, monocytes, eosinophils, myeloid and myeloid dendritic cells, myeloid progenitors. And what is important is that it's expressed in AML, blast, progenitor, and stem cell populations. And the expression of hematopoietic stem cells, it's minimum. So you can see here, this is an example of the differential expression of CD123 in AML patients compared to CD123 in normal healthy individuals. So you can see that it's expression of CD123 based on the populations I described, but there is a difference on the intensity of expression as well as the percentage of cells that express this marker, showing that there is some therapeutic window to target the leukemia cells and not harming the normal cells. So the approach I'm going to talk about is the chimeric antigen receptor CAR-T cell approach, which are engineered receptors that target the target surface molecules, and their activity is independent of the target processing and the signaling, for example, through MHC. The best analogy I can think of when we talk about CAR-T cells is the story of Captain America. So if you're all familiar with Captain America wanted to fight in the war, but he was very small, very weak, but yet he wanted to fight. So after taking some potion and undergoing some sort of weird treatment, depending on the comic you read, he gets transformed in this super powerful individual that is capable of fighting anybody. So similarly, CAR-T cells are T cells that are taken from a particular patient with cancer. They are genetically engineered to be able to identify tumors and eliminate them specifically. So they are soldiers that are created specifically to fight specific types of cancer. So the most common approach used for CAR-T cells consists in taking T cells from a patient that has cancer. The T cells are taken out, they are expanded and activated. Later on, the gene of interest is transferred, the one that will carry the CAR. Then the cells will be expanded and placed back into the patient in order to achieve complete response. The CAR-T cells that we're using in the lab, they are allogeneic CAR-T cells, which they come from a healthy donor. From this donor, the T cells are isolated, purified, then they are transduced, amplified, and frozen in many different vials so they can be used pretty much off the shelf in many different AML patients. So in theory, the advantage of this is that when you use allogeneic CAR-T cells, this process takes longer, and you have to have an individual that has T cells that are enough in number and still active enough to be able to be transduced, amplified, and then placed back into the patient. With this type of allogeneic CAR-T cell therapy, the T cells come a healthy individual, and we should be able to take them right away and place into patients as they are needed. So the particular CAR-T cells we're working on, these are the features. They target CD123. They are a second-generation CAR consisting of 4-1BB and CD3-zeta. And the most important characteristic of these T cells is that they have the TCR alpha-beta knockout, and this is done with the TALENT technology. This is important because this will, in theory, prevent graft versus host disease, which will be one of the major concerns to have allogeneic CAR-T cells put into another individual. Because these CAR-T cells, if they are truly off the shelf and universal, we should be able to place in any individual without having to worry about graft versus host disease by placing these T cells. Another important feature is this RQR8 gene, which it does is render the cell sensitive to rituximab. So it's a construct that expresses CD34, but it has a small mutation that allows the recognition site of rituximab that recognizes in CD20 that allows the specific killing of the CAR-T cells using this drug. So that's a safety switch. If we want to stop the T cells from proliferating in an individual patient, we can treat them with rituximab. So all the data that I'm going to talk about today and the T cells that we use were generated by Selectis, who has provided funding for this work. So the very first thing we did is to see the effectiveness of these T cells in vitro against AML cells, primary AML samples. And we tested different effector to target ratios to see how potent these T cells were. So we tested ratios of 1 to 5 all the way to 1 to 0.5. And you can see here at 4 hours, we start seeing some killing of the AML cells. If you look at the UCART 123 versus the control. But by 24 hours, you can see that the AML cells are completely killed by the CAR T cells at almost all ratios, in contrast with the TCR alpha beta knockout that remains almost intact. Please note that even at lower ratios of 0.5 to 1, we have a sufficient killing of AML cells compared with the controls. This will be important when we discuss the sensitivity to normal cells, which is here. So you can see here we also evaluated the sensitivity against normal hematopoietic cells using the CAR T cells. And we did in vitro cultures. So this is liquid cultures. You can see that there is not too much effect at ratios of 5 to 1 all the way to 0.5 to 1. Because one of the concerns was the potential of eliminating or affecting myeloid progenitor cells. We also did colony-forming assays to determine whether or not we were eliminating myeloid progenitors. And as you can see, the toxicity against myeloid progenitor is dose-dependent. So only at the doses of 5 to 1 ratios, we start seeing some effect against myeloid progenitors, but not erythroid progenitors. But as we go lower to the ratios of 0.5 to 1, we don't see any effect in myeloid progenitor generation. So based on all this data, we wanted to test this in mice, in vivo, and for this we developed some patient-derived xenografts, which consist in injecting primary AML cells into immunodeficient mice. We waited once the animal had evidence of AML, and we started treatment with either the UCAR T cells with the control knockout cells, and we use cytarabine as our control. We started monitoring these mice at day 2, and we continue evaluating and monitoring survival. As you can see here, when we have the control animals with PBS, the animal, this is measuring the disease in the peripheral blood, so the human cells in the periphery. You can see that disease progresses. And in contrast with RRC, we see that early on, after we treat with cytarabine, the peripheral blood blasts decrease, and they stay down for about a week. However, then quickly the animal relapses and eventually has the same levels of disease as the controls. And here you can see the benefit on survival is very limited and is pretty much, again, what is seen in the clinic with AML patients. When we tested the TCR knockout control cells, you can see there is no effect on the progression of disease or in the survival of these animals. Importantly, when we look at the CAR T cells at 2 ratios, in this case 1 million and 2.5 million, you can see that the disease burden decreases and stays down for a very long time, until day 112. And the survival of these animals has a very significant improvement. Here I want to point out that the animals that were shown here as dead with the 2.5 million dose cells of CAR T cells were dying because they were getting old. As we were waiting to see the survival, none of these animals had disease. So going back to what we can detect and what we can measure, we were concerned that as we were evaluating these mice and they appeared to have no disease in the peripheral blood, they might have some residual disease. This is just an example of how you can measure human cells using flow cytometry. It's very few cells that we can detect by flow, so it's very limited what we can evaluate by flow cytometry when the levels of disease is very low. In contrast, if we use digital PCR, designing probes specifically to measure the tumor, in this case, this particular AML had NPM1 mutation. You can see here we can measure the mutation. And we can also design primers against the CAR T cells. So we can measure both the persistence of the CAR T cells and the progression of the disease using digital PCR. This digital PCR also allows us to follow total human ABL as our housekeeping control for human cells, and the mouse ABL to make sure that we have the sample had mouse cells since they come from a mouse. So this was very interesting. This is 2 examples I'm going to show you of 2 different animals that were injected at the lower dose, the 1 million cell dose. So here you can see that at day 134, we can detect CAR T cells in the peripheral blood of these mice, but later on, these CAR T cells drop and they never come back up. When we look at the disease burden of these mice, the disease was low, but as soon as the CAR T cells disappeared, the disease came back and the animal relapsed. When we look at the disease status at day 221, when we sacrificed the mice, you can see the animal had clear evidence of relapse that had blast in the peripheral blood and in the bone marrow, and there was no evidence of T cells in this mouse. In contrast, this other animal that had about the same levels of CAR T cells, the scale is different, but you can appreciate here that it's the same number of transcripts at day 134, maintained the same number of transcripts at day 162. And what was happening with the disease is the disease was present, but started dropping and continued dropping as the CAR T cells started to proliferate in these mice. When we sacrificed this mouse, the mouse was disease-free, no evidence of disease in the bone marrow, peripheral blood, but we were able to measure and detect still CAR T cells in the bone marrow and the peripheral blood. When we evaluated the rest of the cohort, we can see that the 2.5 million cells treatment, none of the mice had evidence of blast. Some of the mice have some T cells present. In contrast, the dose of 1 million cells, we were able to see that several animals had disease present, and very few of them still had CAR T cells present. So, in summary of this very first part, what we can conclude is that UCART123 is an off-the-shelf allogeneic engineered CAR T cell therapy that can potently eliminate CD123 positive AML cells, both in vitro and in vivo. That the UCART123 significantly improved the overall survival in this PDX model. Currently, we have started a phase 1 clinical trial using these UCART123 cells for AML and still is undergoing. So to switch gears a little bit, so we talk about targeting the immunophenotype. I want to discuss that there is another potential way to treat AML patients. And I think one of the most important ways to think about this is that we cannot consider the one-drug-fits-all approach in AML. So I show in the previous slides, and you have heard probably many different ways to target leukemia cells from Greg and Dan here. But what we have to think is that we have to tailor therapies to individual patients. And the particular example I'm going to talk about involves HSP90, because HSP90 has been considered a good target for cancer. And the reason for this is that a normal cell will have HSP90. HSP90 is a chaperone, which role in a normal cell is to fold proteins, specifically under stress. So in a normal cell, we're going to have dimers of HSP90 that are free and latent, and they are going to be recruited to proteins to be folded when there's needed or when there is particular type of stress. So it has been seen in many different types of cancer. When you have oncoproteins, you can form a more specific form of HSP90 that binds to other co-chaperones and to oncoproteins to help stabilize these proteins. Because of that, targeting HSP90 makes sense, and many different HSP90 inhibitors have been designed and even tested for AML. However, the results were extremely disappointing because, as you can see here, this is one example from the group of Lancet that was published in 2010 that showed in a phase 1 study that only 3 out of 17 evaluable patients responded. And because this is a very small % of response, there was no follow-up, no phase 2 trial, and pretty much the interest for HSP90 inhibitors in AML has been decreased. However, if you can note here, there were still 3 patients that responded, and the question is why these patients responded. So we wanted then to hypothesize that in order to tailor therapies for AML, we need to understand the AML network dependencies. And what do I mean with that? The best analogy I can think of this is if I were to ask all of you, how do you feel when you misplace your cell phone? Relax, exactly. Some of you are going to feel relaxed. Some of you are going to feel like this, that you can't live if you don't have that cell phone. Some of you might be a little bit worried, but it's not the end of the world. And some of this, as was mentioned, might be relaxed and relieved that, oh, finally, I can be alone. However, the reference to this is if you feel like it's the end of the world, is because in that phone, in that smartphone, you have all your networks present. You use that phone to pretty much contact the world, to contact your networks, and all of these networks are actually integrated. You know that all of them talk to each other in order to work. If you feel relief, it's because you probably use this cell phone just as a phone. And you know how to find your contacts, you know how to find your networks, you still know where that person lives, you can go find that store, you know how to drive to that place. So there is alternative ways that you have to function and to survive with that smartphone. So the same case is for leukemia cells. What we have defined as the epichaperone is these networks that are these very big, tight networks that are nucleated in HSP90 and HSP70, and because of that, they have high dependency on these machineries to integrate all of these extended proteins that are depending on the integrity of this network. When you have a low dependency to HSP90, you have networks that consist also on HSP70 and HSP90 co-chaperoning. But these networks are so small that if you were to disrupt these chaperones, there is alternative pathways that can be turned on, and this cell will be able to survive. It's like that Jenga game where you have a huge tower built. If you pull one little piece of that game, the whole tower will fall apart. But if you have a tiny tower, you can still pull pieces from this game, and it will still remain intact. So based on that, we defined that there were two types of cancer cells, the type 2 cancer cell, which will have these chaperone proteins that are isolated, where some of them will have HSP90, some of them will have HSP70. The type 1 cell will have these high complexes of networks that we call the epichaperone. And if we disrupt this epichaperone with the epichaperone inhibitor PU-FITC, the cell will collapse and die. What we did is design a flow cytometric probe that will allow us to measure the levels or the abundance of this epichaperone in each individual cell. So when we test this assay, we call it PU-FITC binding assay. If we test this in a type 2 cell, there is no place for this probe to bind, so the fluorescence will be very low. And when we have a type 1 cell, this probe will bind to the epichaperone, and the cell will be fluorescence positive, and the amount or the intensity of this fluorescence will correlate with the abundance of the epichaperone. What we demonstrated is that there was a correlation between the abundance of the epichaperone and the sensitivity of these cells to PU-FITC or other HSP90 inhibitors. This is shown here specifically for AML patients, and here is shown across cell lines. So it's important to mention that this concept is true for any tumor type. It's independent of the mutations or tissue of origin. The data I'm showing you today is specifically to AML, but the principle is still the same across tumor types. Another thing that we found that correlated with sensitivity to PU-FITC or the epichaperone inhibition was constitutive signaling in many different pathways. We just call it hyperactivated signaling networks because the more signaling networks that you have on, more dependencies to this epichaperone will be. And it makes sense because there is so many things going on in the cell that this cell will really be addicted and dependent on this epichaperone to survive. And if you disrupt it, all the signaling networks will collapse and the cell will eventually die. And this is some examples from some of the signaling networks, which include STAT5, ERK, and AKT. So, of course, this is a leukemia stem cell talk. So what we wanted to show is what happens if we test this in vivo, and if we do serial transplantation on these mice, are we able to also target the leukemia stem cell? So what we did is, again, we established xenografts. In this case, we picked samples that have differential levels of activity of this epichaperone. Based, in this case, with signaling networks, we were monitoring the leukemias. So once the disease was established, we treated the animals with PU-H71 3 times a week or with the silent control. We evaluated the levels of leukemia cells in these tumors, and then we did secondary transplants. So here, when you look at the level of disease burden that was decreased after treatment with PU-H71 in vivo, when we look at the samples that have hyperactivated signaling networks or high epichaperone shown here in red, these cells were very sensitive to this epichaperone treatment in vivo. In contrast, as we go down here is the activity of this epichaperone, you can see when the levels of these hyperactivated signaling networks were low, or the epichaperone levels were low, these samples were not as sensitive to PU-H71 treatment in vivo. There was some effect, but it was not as significant as for these AML samples. Most importantly, when we look at the secondary transplants to measure leukemia stem cell activity, you can see here that the only sample that we really were able to eliminate disease in the secondary transplants were the cells that have high levels of the epichaperone. In contrast, the samples that had low levels on epichaperone, there was no effect on the secondary engraftment. And for example, this one, AML9, had even higher levels of engraftment in the animals that were transplanted with cells that were pre-treated with this epichaperone inhibitor, suggesting that what we were eliminating were the leukemic blast and enriching for leukemia stem cells. Therefore, I think it's very important that we really monitor and try to use these biomarkers to select therapies to treat patients that will be more likely to respond to PU-H71 treatment. Of course, this looked very nice, and we also thought so. We published this paper in 2016, and it was very hard to implement in the clinic for many different reasons. AML is not very common, and also because it's the same principles of how we will begin treatment and how to convince you all that this epichaperone is truly an important target, and it generates a very strong dependency in a subset of leukemic patients. So the question for us, can we really use this to identify a single patient that can respond to this therapy? We got a very interesting case. This is, of course, a case of one, but it's a very interesting case report that we found and that got us back on track to incorporate this drug in the clinic. And very briefly, I will explain this case. This is a 61-year-old female that presented in 2013 with a myeloproliferative neoplasm. She had some cytogenetic abnormality that involved the PML gene, and that was all that was known. Nobody knew what was the partner gene. Her disease was negative for all the typical mutations or translocations that were known for this type of myeloproliferative neoplasms, which make it difficult to decide what therapy she will undergo. She was monitored. She started some treatment, but she continued to progress. So she undergo an unrelated bone marrow transplantation in 2014. And unfortunately, she did not respond to this transplant. She continued to progress even after the transplant in 2016. And she was treated with hydroxyurea. She also presented GVHD on a toe and was treated with ruxolitinib. In 2017, she started showing progression to AML and with fibrosis. So she also developed progressing splenomegaly, weight loss. She was treated with 2 cycles of decitabine without response. So she was sent to Precision Medicine, which is a program that Cornell has for cases that are difficult like this one to see if there is any other option that can be provided to this particular patient using sequencing. So what was identified with sequencing was the partner for PML. And the partner for PML was sick. And it's shown here, the translocation between PML-SIG. We validated this by PCR as well as by FISH. So in this diagram, in this PCR, you can really see that the lymphocytes are not involved in the disease, and these are control cells that do not present this translocation. Most importantly, because we wanted to know, and let me just go back for a second just to tell you what happened. So we found the translocation, and we wanted to follow up, what is this translocation doing? However, at the same time, as we want to understand the biology of this novel translocation in this patient, we needed to find a therapy for the patient who had an urgent need for treatment at the time. So the first thing we did is try to see what overall SIG might be doing. So what we did is, in SIG is a tyrosine kinase, we look for whether or not it was phosphorylated, and if we had any other potential targets that were phosphorylated. So in the lab, my postdoc, Mayumi, went and looked at every single antibody we had against phosphoproteins, and what she found is all of them were actually on, which led us to think that, well, maybe this patient has hyperactivated signaling and therefore might be positive for this epichaperone. And that might be an option. So what we did is do this epichaperone assay, and this is here just to show you that we evaluated lymphocytes, blasts, and granulocytes that were present in this patient sample. Here is to show you that the lymphocytes did not have the translocation, the blast and the granulocytes did. And using our epichaperone binding assay, we saw that the lymphocytes were negative for the epichaperone, but the blast and the granulocytes were positive. We tested sensitivity in vitro to this epichaperone inhibitor, and we found that the cells from this patient were very sensitive to the epichaperone inhibitor, shown in blue, compared with the control cell line, MB411, which we know they are very addicted to the epichaperone. So this suggested that this patient probably would be a good candidate for epichaperone inhibitory therapy. So in collaboration with Dr. Gail Robos, she started a single patient IND for this person in order to be able to be treated with PU-H71, and then we can follow up. So this treatment was PU-H71 in combination with ruxolitinib because the patient was already in ruxolitinib because she needed it for the GVHD. We were lucky enough to get this treatment because there was a previous evidence that combination of ruxolitinib with PU-H71 did not have detrimental effects, and therefore was safe to begin treatment in this particular patient. So as correlative studies, what we did was we follow CVCs in every sample in the peripheral blood, in the bone marrow aspirates, in biopsies. We measured epichaperone abundance. We evaluated signaling, and we also measured the transcripts for PML-SIG. We were extremely surprised and very happy to see that when the patient began treatment with PU-H71, the total white blood cell counts decreased to normal levels, and the blast counts also decreased. However, you can see there was a little increase over here of white blood cells and also a peak of blasts trying to come up, because when we started treatment, this treatment was based on solid tumor treatments. We didn't know how to schedule for AML, so the initial treatment was 2 times a week for 2 weeks, and then a rest of a week, and then again treatment. But what we found that week of break was sufficient to let the cells come back again. So we had to intensify the treatment to have it 2 times a week, every week. We continued that for 3 to 4 weeks until we saw that we have complete target engagement and no more epichaperone signaling to be able to stop treatment and then continue once a month. In here, when we have day 221, we start detecting some blasts, in the peripheral blood. So we saw that these blasts were epichaperone positive. Again, with the same assay, we increased the treatment again for 2 times a week, and then the patient went again into remission. So what I want to show you here is that we were measuring the epichaperone levels after treatment in order for us to see we had target engagement. You can see here the control is the lymphocytes in red and the blasts are in blue. You can see that over time, when the patient started going treatment, the epichaperone levels decreased to the same levels of the lymphocytes, suggesting that we were having target engagement and the epichaperone levels were decreased as the blasts were disappearing from the peripheral blood. In addition, we also measured the signaling pathways to show that this also was affected. And over here, you can see the same thing. The blast decreased the signaling as the treatment was progressing. And here we're showing phosphostat 5 and phospho-6 as an example. Importantly, we measured the signaling in the stem cell populations, CD34 positive progenitors are shown here, and the stem cells using CD123 as a marker is shown in here. And you can see that when we compare day 5 to day 11, we can see how the signaling networks start to decrease as the patient is undergoing treatment with PU-H71. So the most important thing is this patient achieved complete remission at day 42. And still she is in complete remission until now. That is a year later from beginning the treatment. Her splenomegaly was also resolved, and she has full hematologic recovery. So the summary for this part is that I show you that we have a novel flow cytometric-based assay that we call the PU-FITC binding assay to evaluate the abundance of the epichaperone at the single cell level. And we were able to use to successfully identify a patient that was predicted to respond to this therapy, and also to be able to monitor and follow up and tailor the therapy of this patient based on this assay. The prognosis of this AML patient that had relapsed from the allogeneic bone marrow transplantation was extremely poor, but now she is in complete remission, and we're currently screening for other potential patients that can be benefited for this treatment. So just to wrap up, I hope I convince you that it's important to target leukemia stem cells, which I don't think I have to convince you, many of you. That we can target CD123 using immunophenotype, specifically using CAR-T cells, and that identifying dependencies of AML cells to epichaperone networks might be a good strategy to eliminate leukemia stem cells and to provide benefit to AML patients. Just finally, I need to acknowledge all the people that have been involved in this work, especially Dr. Gail Robos, because without her, I would not be able to do any of the studies I've been showing to you today. The whole EIPM team, which is the Institution of Precision Medicine, that have been working very actively with us to identify patients that do not have any other options. Gabriela Kiosis, which is our collaborator that developed all the epichaperone inhibitors. Mike Becker at the University of Rochester, still he provides us some samples. Selectis, which provides support, and we have a very good team with them. Marina Konopleva, we have a collaboration with the CAR-T cells, and all the members in my lab, specifically Mayumi Sugita, Holian Song, Sarah, Winnie, and Nicole, who have been involved and have done the work from all the projects that I've shown you. And thank you.
Does the activation of the epichaperone correlate with disease pathogenesis? Does it come up more in relapse than de novo, for example?
We're looking into that. We thought that maybe the patients in relapse refractory will have higher dependencies to the epichaperone because of the heavy treatments. But so far, we see that it's an increased proportion, but still it's not all of them.
And about what frequency or proportion of patients show that phenotype?
It's 40%. So 40% and then goes to 60%, yeah.
In regards to your off-the-shelf CAR, I was curious how you're addressing graft rejection.
How?
You would address graft rejection since they won't have matching HLA to tell.
Yeah, so yes, so all the patients undergo lymphodepletion before we introduce the CAR T cells, and then we monitor them, and of course we expect them to be rejected eventually. The whole hypothesis in here is if everything worked perfectly in this world, you will use these CAR T cells, eliminate the leukemia from the root, and then eventually the CAR T cells will go away. You will have normal myelopoiesis, and everything will be fine. That's in the perfect world. That's what we want to test in the clinic. So we first want to measure if we can have at least short-term persistence and then effective targeting of the AML cells. Yes. Apparently, I do. They're very handy when we want to make analogies.
Okay, thank you, Monica.
Thank you.